start.
Okay,
Ajit, you can start off.
Yes. So, so good evening, friends. So welcome you all for this, Procon session. And today we have some excellent sessions are there. We have excellent speakers are there. We have, the first session is about, do we need to do at least try all the unconventional therapies when all the conventional therapies fail? Is a key question that is, all of us in intensive care face, day by day. And obviously it is very controversial and very, very, debateful, especially in COVID settings. We find a lot of, helplessness, in treating each and every patient on a day-to-day basis. And we have eminent speakers, excellent speakers. Dr. Vivekanathan. Vivekanathan is a senior consultant intensivist from Royal Care Hospital in Coimbatore. And we have another excellent speaker from Delhi, Dr. Anirban Home Chaudhary. He is basically the director and professor of intensive care and anesthesiology at GB Pant Postgraduate Medical Education Research Center in Delhi. And I think first of all the Procon debate. The pro is with Dr. Vivekanathan. So Dr. Vivekanathan is going to be for this for the concept that we need to do everything and we need to go for unconventional therapies also. That is what Dr. Vivekanathan is trying to argue on that, and we have Dr. Anirban Chaudhary will be opposing that. And over to Vivekanathan.
Thank you, Dr. Ajit. Thank you for the introduction. We should always try innovative therapies when established therapies fail in COVID setting. That's the statement given to me. Warm greetings to all of you from Royal Care Super Specialty Hospital, from the Institute of Critical Care Medicine. On behalf of my colleagues and staff, welcome you all. Well, let's set the scene by talking about the context. It was later in 2019 when the facts were uncertain, what is going on, and mortalities were rising. The stakes were high, healthcare was at stake, and the time was running out as well. And people were looking for some evidences as to how to treat such a pandemic that has come out of nowhere. It was a perfect storm, as written in the editorial by Frontiers in Public Health. It was well sounding, the perfect storm, the coronavirus pandemic meets overfat pandemic. So what did we try out of desperation? Well, with the way that the COVID virus was affecting entering the body.
Sir, you'll have to share your screen, sir.
Is that visible now?
Yes, sir.
Yes, Vivek, you can continue.
All right. So warm greetings again. And the pandemic was in place. Facts were uncertain. There were quite a bit of mortalities happening. The stakes were high, both in healthcare and also in the economic world. And time was running out. People were looking for evidences as to how to treat patients. So it was a perfect storm. So that is the context. And WHO announces the world that it is a pandemic on March 11th, 2020. What did we do out of desperation? Well, the virus was deemed to enter the body through the ACE receptors. So even people who are on ACE inhibitors started avoiding ACE inhibitors so that they can downregulate the receptors. And people started using antimalarials, chloroquine. People started using azithromycin, ivermectin, antivirals, which were in place for different disease, steroids, and the plasma therapy. Two things were started in use. And no specific antivirals being effective. This was the statement made by the Ministry of Health, and from India, certain bodies got together and looking at the evidences, they came up with this, that you could potentially use off-label indication drugs such as hydrochloroquine and azithromycin, and you could potentially try corticosteroids. So from an innovative way that people started using certain drugs, there were suggestions from societies and from the head of the government, suggestions that you could potentially use what is available and what was deemed to be useful in such circumstances. So it was a perfect problem that COVID pandemic posed. There was no evidence. How COVID broke the evidence pipeline, that was very evident. And people started resorting to what was available as before, that the COVID was struck. Before COVID, we were all relishing the evidence-based practices. There was evidence for most of the things. So you were relishing prior to COVID, what are all the evidences that were available in our day-to-day practice. But once COVID struck, there was no evidence to rely upon. So there was a start of so many trials, which all started off as innovative therapies. So looking at the trials as such, what was available, you could come look at this picture where nearly 40% of the trials that started were inadequate in the number of patients that were recruited. So nearly 40% of them had less than 100 patients. And how about how many trials were in place? There were loads of trials. There was an uncoordinated approach to the problem. There were literally more than 200 odd trials on just hydroxychloroquine alone. So what was it going to tell us? So it was totally uncoordinated response that was not going to give a clear picture as to what could the therapy be for the COVID patient. This is an important slide that we need to amalgamate practice-based evidence instead of evidence-based practice. So this is a perfect context where we are lacking evidence-based practice. So practice-based evidence is what was coming into fore. So you were going to rely on, I'm going to give hydroxychloroquine and see what happens to the patients. It is not on an experimental basis, but if these things were going to work and I'm going to see some responses, then I'm going to rely on this practice-based evidence to make some policies which were taken up by the government and later on led to evidence-based research. So what exactly is innovative therapy? Well, it is newly introduced or modified therapy with an unproven effect or side effect, and it is undertaken in the best interest of the patient. Let me stress upon best interest of the patient. So if I were to practice innovative therapy, then there is a conflict. Am I withholding the potential rescue therapy? Or at the same time, I have the responsibility of protecting the vulnerable population as well. So these are the two conflicts that I need to address for the patient's best interest. I cannot withhold potential rescue therapy either. So comes the framework of ethical nature, where I have to uphold patient's autonomy. At the same time, instituting innovative therapy, I will be governed by professional consensus, and I will have institutional standards to uphold. At the same time, this innovative therapy will lead on to early clinical research with ethical principles, resulting in standard therapies. So those standard therapies which have been proven with clinical research is what the paving way should be for the innovative therapy to result as. So innovative therapy represents a justifiable departure from the inferior conventional therapy in the absence of accepted standard therapy. Helsinki Declaration by the World Medical Association, which was formed in 1964, explicitly tells you that in the treatment of a sick person, the physician must be free to use new diagnostic and therapeutic measures if, in his judgment, it offers hope of saving life, re-establishing health, and alleviating the suffering. So the potential benefits should outweigh the hazards, discomfort, definitely. So the Belmont report also upholds the ethical principles in terms of autonomy of the patients, beneficence, trying to do the best for the patient, non-maleficence, not doing any harm, and have to make justice that who should benefit and not necessarily someone should come to harm as a burden out of that. So on innovation, Belmont report elaborates that interventions that are designed solely to enhance the well-being of an individual patient have a reasonable expectation of success. So if I expect certain success with that therapy, then it should and could be done for the patient, not necessarily withholding that benefit. I am not going to twist the truth. Innovation is then when a clinician departs in a significant way from the standard or accepted practice. But it is the innovation that is going to lead on to clinical research, where it is an activity designed to test the hypothesis, permit conclusions to be drawn, and it will become a generalizable knowledge. So from history, we know very well that anti-inflammatories, anesthesia, laparoscopy, pacemakers, they were all introduced and developed in clinical practice even well before they were found beneficial by clinical research. So what we need is a permissive oversight approach. Innovation per se has two difficulties. One, there are hardliners who will argue that it should be banned. End of story. Proscription by hardliners, that is against innovation. That is a big problem. Then number two is the runaway diffusion, where somebody thinks who is pro for innovations, oh, it works very well, shall we go ahead? And people tend to carry forward without any clinical research in place. So that is another problem with innovation. But these can be overcome very well with prospective peer review and enhanced informed consent procedures. These two things, if they are in place and endorsed by the societies, which is in place now, it can very well lead on to early transition to clinical research for establishing the therapies. And what we need is the epistemic competence, even without evidence or with evidence, to judge the knowledge, the justified true belief, the knowledge, with the concurrent, whatever evidence is available, to come to a conclusion whether this will benefit the patient or not. So let us come to the context of COVID, that COVID therapeutics, there were quite a few anti-inflammatory agents, antivirals, antimalarials, and even the vaccine. So therapeutics and the preventive measures in terms of a vaccine. And COVID pandemic did create a perfect context for innovation, albeit newer therapies would have never involved. So we did come across this drug. Hope everyone recognizes it. Out of every 100 patients on the ventilator, 60 will die, whatever we do. Out of the 40 people, the 60 patients are likely to recover. Out of the 40 who are going to die from the mechanical ventilation, 12 patients will survive by using this drug. Have you guessed it? 1 in 3 on ventilator will survive from this medication. 1 in 5 on oxygen during the COVID, if used, will survive. What is it? Yes, it is a breakthrough. BBC came up announcing the pandemic drug that could be a relief for all of us, which was the steroids. So what did we know of steroids prior to the pandemic? Steroids were probably not effective when used in MERS, the Middle Eastern respiratory syndrome pandemic, and when it was used in influenza as well, probably it was not effective. But it took an innovative step to use it way back in end of 2019. In December, China started using. Some of the physicians at the forefront of tackling the huge problem started using methylprednisolone, and they recommended short courses of corticosteroids, glucocorticoids, and they came up with the data. The initial data was promising, and they went on to trial it, and it was UK which took the burden off and easily coming up with a protocol. And by the middle of 2020, we had it in place, the clinical research telling us that COVID can be tackled with steroids, and there will be quite a bit of benefit in terms of mortality benefits as well. That all started with innovation. What about self-proning in COVID-19? We knew from physiology that proning results in a homogeneous ventilation. It is clear. But how would it translate into clinical practice? Well, from before that we know of from the trials of ProSeva that in ventilated patients, it is beneficial. And later on, Thompson et al. Took the first innovative step of experimenting in 25 patients, non-intubated, who are hypoxemic with respiratory failure to go prone themselves. And this innovative approach did help during the pandemic when there was a huge surge in need for ventilators. And later on, even the societies and the top officials coming up with suggestions that you should go prone as even for patients who are not ventilated. So it was found to be beneficial later. And how did it come to the fore? Well, there were initial experimental decisions that were taken with the emergency department, somebody experimenting in patients with hypoxic failure and reporting it. Later on, Intensive Care Society in UK did the recommendation. Then came the RCTs, ApprovCare and ProFlow, detailing what are the effectiveness, what are the shortcomings, and what are the current variabilities that we come across in day-to-day practice, practicing self-proning. So incorporation into practice with the caveat, using the evidences to date has resulted from the initial innovation. So these two cases explicitly tell you that innovative care is the start of evidence-based medicine. So what do we know of in preventive therapy? Well, Edward Jenner innovation, when he started injecting his gardener's son with the pus of smallpox, is the start, and it has started saving millions of lives. And pandemics do culminate in innovations. Within the last 16 months, we have seen the delivery of the first ever mRNA-based vaccine. That is again an innovation. It has got potential repercussions later on as well. So what next? So as it has been put by the CEO of Pfizer, the only rival is the virus and the only competitor is time. So we are looking at, people have been looking at newer molecules, remdesivir as an intravenous therapy, not suitable for oral use. Now they are looking at inhaler usage as well. So innovation is the ability to see change as an opportunity. It should not be perceived as a threat. So pandemic lessons, we have seen over the ages that COVID now is going to result in a new era in healthcare, which is going to be a digital health. Artificial intelligence algorithms have predicted outbreaks. At least 10 out of 12 cities, the outbreak was predicted by artificial intelligence. Analyzing possible treatments, and how are we able to speed up the clinical trials? It was all due to artificial intelligence, making diagnostic treatment aids as well. The concept of design thinking comes into fore with the creativity and innovation. Creativity being a divergent thinking and innovation a convergent thinking to come up with the idea to identify the most possible potential solution to the problem and to implement it in practice. So design thinking combines creativity and innovation in a structured approach. So would we have ever thought, as published in the BMJ Innovations, that somebody can predict a mechanical ventilatory need within 3 days just by looking at chest X-ray? Artificial intelligence did make an impact. This is purely an innovation. The concept of digital thinking on the design thinking has made a new inroads in India as well. I wanted to highlight this paper to you from Karnataka Pediatric Journal in Pediatrics, where Dr. Srinivas has highlighted this fact. As clinicians, we have always practiced innovation at some point of time in our career when we would have faced a resource crunch and we were compelled to do the best for the patient. And hence, we have tried to innovate on devices, processes in our own way, and has worked many a times. ICU innovations that have stood the test of time, steroids to date, we have been using self-prone positioning, we have been using use of HFNC with wider ramifications has come into fore, and use of NIV with caveats has come into practice. I reiterate, we should always try innovative therapies especially when established therapies have failed. That too, the COVID pandemic has set the context very well. I wish good luck to my opponent, Dr. Anirban. Thank you.
Yeah, you are muted.
Ajit, you are muted. Ajit, kindly unmute. Yeah, I think Ajit is muted. So thank you so much, Vivek, for that excellent overview on why we should be using innovation. So without wasting much time, I hand over to Dr. Anirban to do his rebuttal on this. Over to you, Anirban.
Thank you, Mr. Speaker, sir. While I was listening to my learned opponent who was building castles in the air, I was wondering whether he had the ladder to climb the castles. And then I realized that it is good if he doesn't have, because then nobody will live in there. So it will be a harmless endeavor. Mr. Speaker, sir, the subject for debate is, in the opinion of the House, we should not always try innovative therapies if the established therapies fail in COVID settings. And in this context, I wish to bring before you the very distinction between established therapies and innovative therapies in the context of this debate. Sir, should we consider established therapies as non-innovative? Definitely not. But established therapies are accepted as standard by regulatory bodies and by bodies of scientific experts, while innovative therapies are yet to gain an acceptance as standard either from the regulatory body or from the scientific body of scientific experts. So this whole journey from innovation to establishment is a process of the same continuum. It is the same straight line. At one end, we have some therapies which have not been accepted by the community, and the other end which have been accepted by the community. So during this process of journey, some drugs evolve and some drugs or some mechanisms involute. So they go to the dustbin. Is it meaningful, Mr. Speaker, sir, to challenge this normal course of transformation and try to prioritize something beforehand in anticipation that it is going to deliver? Yes, it is true. It is true if we are trying to start the shooting of a film even before writing the script. So in that case, it may suit, but certainly it is going to be detrimental not only to the patients, but to the entire society as a whole. Mr. Speaker, sir, I wish to bring to your notice this wonderful Procon database review, which answers this basic question. On average, how often are new treatments more effective, equally effective, or less effective than established treatments? I am not going into the detailed A of the study, but if you see that this study spans over a period of 60 years because it collects the data from 1950 to 2010, it was published in 2012. But it is said that the society can expect that slightly more than half of new experimental treatments will prove to be better than the established ones which are tested through RCTs. Few will be substantially better. Mr. Speaker, sir, this means that another close to half are going to enter the dustbin. So I want to ask you, Mr. Speaker, sir, what can be the justification in trying to use the therapies that might eventually get thrown into dustbin in no time? Mr. Speaker, sir, I wish to bring before you this beautiful concept of sensible medicine during balancing intervention and inaction during COVID-19 pandemic, published in JAMA in October 2020. If you carefully looked into this slide and understand the conceptual model of sensible science or sensible medicine, Mr. Speaker, sir, you will be able to appreciate that if our skepticism is low, but if our degree of intensity in clinical approach is high, we gradually move towards this phenomenon of hawkish interventionism, which is absolutely detrimental in no uncertain terms. So we should reserve this degree of high intensity of clinical approach only when we have a high skepticism of a new evidence, so that the pace of knowledge translation can be endeavored upon. Mr. Speaker, sir, our only approach would be to adapt to a new treatment only when the evidence is rigorous, reproducible, and sufficiently strong in all possible clinical settings. Mr. Speaker, sir, I would like to clarify that sensible medicine does not mean that clinicians should not intervene, but it means that we have to adopt a gentler, moderate, and humble view of the available options and their effectiveness. We have to elevate usual care, reduce unnecessary interventions, and rely on our scientific rigor. And that comes when we give importance to supportive restraint and heighten therapeutic humility. Sensible medicine can only come, Mr. Speaker, sir, we find out what has caused the established treatment to fail rather than jump into non-established therapies. Mr. Speaker, sir, I wish to bring to your notice this wonderful book by Nassim Taleb called Antifragile, in which there is a context where it says the illusion of control that can lead to a default of action rather than inaction. So this is true that for many medical emergencies like cardiac arrest, pulmonary embolism, tension, pneumothorax, etc., this can be a reality for the clinicians because intervention can prevent death. But what if there is no medication, if there is no clue, then that default action can be dangerous. And the only answer that come from, which can be in the interest of the patient and for the society, can come from sensible medicine. Mr. Speaker, sir, I don't want to tell this whole tale of Zygris because we all know it. How this wonderful drug, the so-called wonderful drug in 2002, which was granted new technology status, which became bundled into the standard of care of many hospitals, was made the company was compelled to remove it from the market with FDA encouragement. But this is not one story. It has been a saga for ages. Mr. Speaker, sir, if we look into these two trials in COVID, which have been published around the same time, one is the together randomized control trial and another is the coviferone randomized trial. If we look into the one where we find that neither hydroxychloroquine nor lopinavir-ritonavir showed any significant benefit. Other trial, we find that the interferon beta 1 has been found to be benefit. Does it mean that interferon therapy is useful and HCQ therapy is useless? Not at all. Mr. Speaker, sir, the entire process of research is based on the assessment of various variables, be it patient-related variables, medication-related variables, and the subsequent journey that the clinical trial undergoes after encountering drug-related problem, pharmaceutical validation, so on and so forth. So a therapy is never established based upon a single outcome from a single study. It is based on the basis of the observations that it accrues over a period of time and in this process of journey. And this time is variable. It is not for same for all the therapies. Some may be lucky, like a few, which gets highlighted in no time, while for some others, the clinician has no clue. And particularly, Mr. Speaker, sir, in a situation like COVID, when we had all classes of drugs being researched over a small period of time, commenting about the usefulness or lack of usefulness, that is uselessness, can be not only challenging, it can be dangerous because the same drug can spell it out in a bit. So does that mean we cannot use innovative therapies at all? No, Mr. Speaker, sir, my submission is to the contrary. To facilitate this, the regulatory authorities issues emergency use authorization. So those drugs which have got some evidence, they can come under that category. So once they come under the category, they fit into the category of expanded established drugs. We have monoclonal directed therapies. We have emergency use authorization for convalescent plasma since 2020, baricitinib, tocilizumab. Even the currently ongoing WHO Solidarity Plus clinical trial has 3 new drugs, artesunate, imatinib, and infliximab. So there is a scope to use innovative therapies within the broader umbrella or tentacles of established therapy guidelines. Mr. Speaker, sir, there is a saying in that better late than never. But when it comes to trying all out with the treatment, there comes a point where we have to learn to accept treatment futility. We know that every treatment has a goal, and our therapy has a goal. But when there is an action and activity aimed at achieving this goal, and there is a virtual certainty that that action will fail in achieving this goal, we have to realize that probably it is the time to negotiate transitions from aggressive treatment to comfort care with the patients and their families. We cannot ignore it. This is the hard truth of medicine. Mr. Speaker, sir, not all innovative therapies are of the same magnitude. Although they are all considered as innovative, if we try jumping guns over the new therapies one upon another, then we will start use drugs in the pretext of innovative therapy, and ignoring those regulatory approvals, ignoring the quantum of scientific evidence, then that is not only going to be unethical or detrimental, it will be pure recreational, and we cannot afford to create recreation with our patients. Mr. Speaker, sir, I don't want to stretch my debate on on the ground that overzealous drug therapy can do more harm than good, because that is known and that is not the theme of this debate. But that is certainly important in understanding the fact that my learned opponent and his team members to realize that let us first write the script, then choose the actors, and finally start shooting the film. Mr. Speaker, sir, I rest my case. Thank you all.
So good evening. Thank you, Dr. Vivek Nathan and Dr. Anirban Chaudhary for an excellent presentation. Dr. Vivek Nathan, you need to add anything to Dr. Anirban's arguments? You need to have any kind of discussion, rebuttal?
Yes. Sure, Dr. Ajit. Thank you. I think Dr. Anirban made an excellent statement. And all arguments by Dr. Anirban, I think it would hold good if we were to have all the time in the world. We would have excellent display of gourmet of evidences in place where we can easily dish out the evidence that we want and then use that evidence, and we would be very happy. But unfortunately, in the context of COVID pandemic, we haven't got enough time for all the clinical research with all the methodologies to fall into place to come and give a solution for each and every problem that we have got. So I think you still need to rely on innovation to start off the therapies, and you need to subject them, as it was rightly said, to early clinical research. So innovation, we wouldn't be here with an excellent molecule of the steroid in place, treating our patients, reducing mortality. So I would start off saying every established treatment had early innovation in place. So I would go back to the slide Dr. Anirban had used in his presentation, the Cochrane review, which was presented in 2012. And they went on to investigate how often the new experimental treatments that were evaluated in randomized controlled trials are superior to established treatments. So what did they have to look at? So nearly quite a huge study in terms of RCTs included, nearly 700 RCTs, huge number of patients, and 4 cohorts of RCTs were analyzed. And the results in favor of new treatments or established treatments were looked at. In terms of meta-analytic pooling, new treatments were slightly more favorable. Well, that was the point that was highlighted there, but there was no heterogeneity that was observed, and the meta-regression demonstrated that results have remained stable over the years. That was highlighted as well. And the results were not significantly affected by the choice of comparator, be it a placebo or be it no therapy. So the author's conclusions were pretty clear. can expect a slightly more than half of the new experimental treatments will prove to be better. Let me reiterate, it's more than half of the experimental treatments will prove to be better. Let the rest of less than 50% be thrown out of the bin, but they went on to be established later. So it's an important finding, even for patients, when they were contemplating whether to participate in the RCTs or not. It's a good point for the researchers. They can plan the design very well. And for the funders, so definitely somebody will fund for such explicit clinical researches as well. So looking at the kernel density on the overall survival, there is a clear-cut deviation from the midline to the left for new innovative therapies. Looking at the forest plot comparisons, the primary outcome, if you were to look at the forest plot, is favored over the established in these RCTs. Looking at the survival benefit, there is a clear-cut benefit for the innovative therapies. More evidence from Julbigovic in 2000, it clearly states 44% of the randomized trials favored established treatment, whereas 56% of the trials favored new treatments. That's astonishingly good. So if you were to adopt, be not proscriptive, not to annihilate the innovative therapy, then you could adopt what is in place, what has been adopted around the world in terms of design thinking model, which is very well established around the world. Especially, I would like to quote the Stanford Medical University, where it has been emphasized that we need to empathize the situation, understanding the clinical context. Where are we at? We are the COVID pandemic, and we need to empathize the mortality that is on the rise. Define the problem, what exactly is the nature of the problem, and ideate with an innovative solution. And we need to develop an interventional therapy, or be it a device, it has to be prototyped. Only then it can be subjected to clinical research. So early submission to clinical research of innovative therapy is what is going to come into fore and make a stand. So the bottom line I wanted to make is the context. The COVID-19 pandemic has arguably been one of the greatest challenges to evidence-based medicine since the term was introduced. An ethical approach overseeing this innovative practice must encourage early transition to clinical research without any delay, so that we will reap the benefits of the innovation. And without having a change of mind to accommodate the innovative therapies, innovative devices, we are going to be at loss. So if you're going to adopt and have a change, only then we will have the opportunity to come up with an excellent established therapy. It has to happen within the right framework, which I totally agree and endorse upon. Thank you.
Thank you, Dr. Vivek Nathan, Dr. Anirban Chaudhary, for the excellent discussion. So, Anirban, you need to add anything? We'll just give it to the audience. Any comments from the audience?
No, I have.
We have only 5 minutes left. We have only 5 minutes left.
My rebuttal is there, na, Ajit?
Yes.
Mr. Speaker, sir, my learned opponent has tried to bring a ladder, but unfortunately that ladder is too weak. It remains to be seen that if established therapies fail, or if established therapies deter the use of an innovative therapy, under what certain terms can we think or we try to use a therapy, and that in that it will cause benefit, unless we get an emergency use authorization which comes from the regulatory body. And if it doesn't come, we are sorry. Then the basic ethical principles that which he was commenting upon, which is based upon beneficence, non and maleficence, autonomy and justice, gets violated. And if it is accepted, then it is no longer innovative. It is innovative as well as established, because it has received the emergency authorization use. I again reiterate that the subject for debate is innovative therapies should always be used in when the established therapies fail. And I still stick to my ground that it should not be always used when the established therapies fail. If, as my learned opponent had tried to point out, the limitations of research, yes, I know there are limitations of research, but there are ways out too. In a situation like COVID, we have newer designs, better designs of trials, like the platform trials, the umbrella trials, the basket trials, which takes lesser time, can find out multiple therapies, can make adaptable design, and they come out with a solution. Mr. Speaker, sir, I rest my case saying once again that innovative therapies can only become real in the real world once they attain the status of established therapies. Thank you, Mr. Speaker.
Thank you. So any comments from the audience? Dr. Pradeep? Dr. Justin?
There was a question I saw from Justin, that what is the difference between research and innovation? Justin, I think research is the cause, innovation is the effect. If we don't have research, we don't get innovation. And innovation only follows research. Research may lead to innovation, it may not lead to innovation, but innovation is always preceded by research.
So Dr. Anirban, can we see when we are groping in the dark, like in COVID? So don't you mean to say that no, the innovation can be incorporated as part of the research actually, rather than sporadic sort of use of different medicines and different intervention by different physicians or different patients?
Ajit,
so if there is with the consent of the patient and the family,
outcome. Innovation is the outcome of research. So in order to reach an outcome, in order to get a good recipe, you will need some amount of good dish, you need good recipes. So if you don't have the time to make good recipes, if you don't have a good batter, what you try to use certain designs which can make a good batter quickly. For like I told you about platform trials. In platform trials, you can use multiple interventions. There is an escape route. That against their control arm, one group of drugs enter, another group escapes, so that within the reasonable time frame. So you alter the design. So thereby you reach an outcome which is more scientifically evident.
May Button, I beg to differ from points. And the classical way that we tend to come up with a hypothesis in a clinical research is with an innovative idea. So without a hypothesis, which is practically an innovative idea, and be it a therapy or be it a device that is going to be interested upon patient's autonomy, and none of this will be feasible until you come up with an innovation and then put it to clinical research and make it robust, looking at the effectiveness of it and looking at the shortcomings of it, the side effects of it. Only then you tend to realize if that innovation or the innovative idea, innovative therapy, innovative device was good enough or not. So within the context of COVID pandemic, I would argue that we need to think differently. There should be a creative thinking, and then you need to put that idea into place well within the frames of ethical framework. And that is where the key is, that we need to be encompassed within the ethical framework and make these ideas come into bloom as an established therapy. Thank you.
As long as it is a thought, it is an idea. And when this idea is put forth into research, it becomes an innovation.
Yeah. Can I just make a couple of comments, and then we'll take one or two questions and then we'll close. So very well conducted, Vivek and Anirban. So Anirban is a hard debater, so it's not easy to overcome his stand. So if I can draw a middle ground, Anirban and Vivek. See, I think COVID pandemic has really thrown a lot of challenges at us. And what really came out of this whole challenge is there was one country which was very systematically, I mean, many countries actually, which were systematically collating the data and trying to look at it from a systematic standpoint as to what interventions is really helping, and the recovery groups especially, because these are the guys which were well appreciated in many editorials. They were constantly collating the data of multiple interventions each individual or each organization or each country was believing and adopting. And they dissected it out and they came out with some logical answers at the end. So I think that should be the spirit of scientific rigor, that whatever we use, we have to possibly look at it from a research standpoint and try to come out with the data so that we could deliberate and dissect out the data and drive some logical conclusions. I think that should be the take-home message for the audience. So can I get agreement on that, Anirban and Vivek, that
Yes, yes,
whatever
I
innovations
fully
we
agree.
do,
I
because
fully
if
agree
you,
with the chair.
yeah, no, I'm not the chair. Ajit is the chair.
Ajit,
No, no, no.
No, the reason is the whole spirit of our evidence-based medicine or the modern medicine has evolved from Hippocrates. And if you see Hippocrates, what he did, he continuously charted his own findings of recording the pulse and making some conclusions at the end. So the spirit of the whole audience here should be that use innovative, but chart out all the findings that you have and publish it and share it and deliberate upon it and get critics to review it and take corrective mechanisms and then reach a logical conclusion would be the take-home message for me. So any final comments from Ajit? There is a gentleman from Uganda who I just, Dr. Tim. So Dr. Tim, I welcome. So he has made a comment. I'll just read out his comment. I think this pandemic put a lot of pressure on us amidst high desperation levels. People were grasping. However, this doesn't mean we should lose our professionalism and mandate to technically guide the masses and our government. That said, as long as the theory is scientifically correct and gives desired outcomes, there's no harm in studying new innovations. So that's Tim's comment from Uganda. But to add to that, Tim, I think we should collate the data and share it and publish it and then make some logical conclusions. Ajit, your final comments and we can close it.
Yeah, that's the thing. So the innovation, definitely you need to see. What I believe that innovation need to be, incorporated in a very organized manner. That to make it a research. See that it should not be some kind of a sporadic, different innovation tried on different patients, and so you're not going to reach any kind of a conclusion on anything. So it should be an organized sort of incorporation of the innovation. And we have to convert that into some kind of research, and we should have some answers on something, and we need to go ahead. That'll be my take on that. I agree with that. I well argued, Dr. Anirban and Dr. Vivek Nathan. I think we'll just go to the next.
Any final comment from Justin? Justin is here. Our good friend.
Yeah. So I was just trying to agree with both of them, and I think the a follow up to my question about research and innovation. So. Like Anirban said, which was 100% true, that we draw inspiration from available research by coming up and using that in an innovative way so that we can tackle a new problem, which is what we see with the remdesivir. Remdesivir was researched as an antiviral agent, broad spectrum antiviral agent. And suddenly, when the world is looking for another antiviral to combat COVID, they looked at all antivirals. It wasn't like they suddenly it came out of thin air. It was a body of literature that it is a broad spectrum antiviral, but it was innovative steps to use. And when the implementation of innovative idea comes with acuity, that means how rapidly that we need to deploy. And number one. Number two is that whether it is a rarely occurring event or commonly occurring event. And in both instances, it would drive the speed with which we would use it in a clinical practice, with or without. Unfortunate side effect, which I probably also agree with Anirban, is that most of these practices, once included, will not go away, like how we are seeing with the prescriptions of zinc. The prescriptions of so many medications that are unwanted are still being done in COVID, even as we close to third wave. And we haven't, as good as innovation is, that it leads a behavior change in the community, particularly, which would take a lot longer to go away, because it is easy to reason.
Justin, that's why I showed the slide of sensible medicine.
Exactly. So there is, unfortunately, there is no sensible medicine. This is called, in a pandemic, when there is innovation, it changes. There is a significant body of literature about how an urgency changes one's behavior. And these are all what we call a principles of morality. And they're doing the right thing for the right reason is something that takes back step. And then everybody thinks that they are doing the utilitarian model of we are doing the best for the most, which isn't true. So these behavioral sciences prove that as good as innovation is, it is quite harmful for these. Even if you take the RCT list of nearly 50% being positive for a neurointervention, the rest of them will be continued or maladapted or malused. And so essentially you put that much risk of exposure to drugs and side effects and healthcare costs and increasing the morbidity, at times mortality. So that is something, the dark side of the innovation is that particularly in a commonly occurring and rapid response, that we see that side effect. I agree with Anirban on that slide. Yeah.
So can we go to the next topic, Justin?
Thank you very much. Thank you, Dr. Vivekanathan.
Thank you, Dr. Anirban.
Yeah, thank you, Anirban.
Lawyers,
Thank you,
as I
Vivek.
told you before, lawyers after the debate have tea together. So it is not possible virtually, but outside the court, it is all the same. Thank you. Nice meeting you.
Thank you. Excellent discussions, Dr. Anirban, Dr. Vivekanathan. Now we'll go to the next topic.
I wish to beg for your excuse because Yash is repeatedly calling me for the other engagement. So
Yeah.
I please beg your
Thank you.
pardon.
Thank you, Dada. Thank you, Dada, for being part of this. We'll engage you in more such debates. Thank you again, Anirban, from all
Always
of our region. Thank you.
So next session, we have an interesting discussion, Procon debate. The routine ultrasound is a must in the ICU. And the person who is arguing for this is Dr. Radha Mona. She is a senior consultant in intensivists at Damaya Memorial Medical College Hospital, Bangalore. And against this, she is prone for this, concept of routine ultrasound in the ICU. And against Dr. Radha is arguing Dr. Sharmali Sinha. She is senior consultant at Apollo Hospitals, Bhubaneswar. And she is going to argue against the concept of routine ultrasound in the ICU. It's a must in the ICU. Over to Dr. Radha.
Thank you, Dr. Ajit. Whether I'm visible?
Yes.
Yes, you are, Radha. You can start off.
So at the outset, I would like to thank Dr. Ajit, Dr. Pradeep for this opportunity. I strongly believe that safety isn't expensive. It is priceless. So we need to prepare, prevent, and we should never repent. If at all there is some repair activity needs to be done. People, safety, quality are more than a priority. They are a value. So I definitely would like to start my proposition for ultrasound routine use in the ICU with 3 clinical scenarios. This dates back to almost 10-12 years behind. So I was a fellow getting trained. A middle-aged lady with constitutional symptoms was admitted in our ICU with respiratory failure. She was hypoxic, hypotensive. There was nothing to suggest sepsis though. There was a progressive trajectory within the couple of hours in the ICU, and she was intubated. Bedside ultrasound in the ICU, it was really surprising to me. It was a cardiac tamponade. And the same evening, my teacher and mentor had taught me how we are supposed to assess the cardiac tamponade. So here, the cardiologist on call was really obliging to me. He made me to put the pigtail and patient survived. Later on, it was adenocarcinoma of the lung and she required radiotherapy. Probably for some months, she did survive. The second patient I would like to say here, the clinical scenario is a post-operative elderly female. She was post-surgery moved to ICU. It was a large malignant ischemic infarct. She required decompression for the same. She was in refractory hypoxia when we received from the anesthetist. According to him, it was probably a neurogenic pulmonary edema. However, the compliance was good. Even on FiO2 of 1, the saturation was hardly 80, 85 or so. The endotracheal tube was crystal clear. So my mentor and teacher didn't leave this patient. Within few minutes, he could make the diagnosis. It was a PFO. The third scenario, it was a laryngeal carcinoma patient who developed a stridor in the ward and subsequently moved to ICU. Again, my teacher did percutaneous tracheostomy. From the medicine background into intensive care, I realized that definitely if ultrasound was in our curriculum earlier, probably like 1990, Dr. Daniel Lichtenstein started international movement. However, only probably to my knowledge, 2010 onwards, ultrasound usage is more common in the ICU. If at all, we used to use ultrasound, so many diagnoses we could have made and probably many patients could have been saved. So along the journey of many intensivists, ultrasound would have not only helped in diagnosis, definitely would have made a big impact in the patient's outcome. Point of care ultrasonography definitely is a holistic approach. It's a holistic application. Few innovations in critical care have really changed the intensivist practice. And in that, I would definitely say point of care ultrasonography stands first. It has revolutionized the bedside assessment of critically ill patients, and definitely it complements our clinical examination. So many of the experts in this field say that it is a stethoscope of 21st century. I feel privileged and fortunate to be in the era of pure visual medicine. Again, the full credit to ultrasound usage by the intensivists in the ICU. As a frontline critical care specialist, it not only helps me in diagnosing clinical scenarios, whether it is respiratory failure, whether it's a cardiac failure, it also aids me in swift management of patients with life-threatening conditions. So apart from the diagnosis and therapeutic implications, it has become a standard of care in procedural guidance. So over a period of time, various protocols have been established and have made a significant impact. I feel with Blue Protocol, False Protocol, CSAM Protocol, definitely we are more objective as far as the assessment is concerned. Definitely the result is a better outcome. So Dr. Daniel Lichtenstein, probably the father of ultrasound lung, it has made one standard statement that it's a reasonable bedside gold standard because it has more than 90% of accuracy. Why I'm emphasizing so much on point of care ultrasonography? I'm a strong proponent of ultrasound in the ICU because it has a lot of advantages as far as the ICU patients are concerned. Excuse me. Our patients in the ICU have dynamic pathophysiology. So not only in diagnosing, it helps us in therapeutic also. So we are able to make quick decisions whenever we do a particular diagnosis. And it is safe because I don't have to move my patients with multi-organ support to CT console where I'm worried whether any kind of mishap happens during the transit or within the console or while the patient comes back, and it is user friendly. Because our patients are in the ICU, we are only assessing, we are only interpreting, definitely it is saving time and better adequate correlation happens with the intensivist doing the ultrasound because it is goal directed and it is very well focused. And in one of the study, in one of the article, it has been said that it took only 8 minutes for a first year or a second year resident to do the whole body ultrasound. Definitely we can think that time is so precious because we are not doing many of the investigations like CT or X-rays recurrently. Definitely cost is saved. It is non-invasive and it is repeatable many a times. For example, if a patient is in septic shock, if I assess the patient is fluid responsive, definitely I'm interested to see whether what my PLR is doing or what my IVC is after the fluid resuscitation. So I can repeat that not only in diagnosing and whatever my intervention has made an impact as far as the patient's pathophysiology is concerned. And definitely there is a fast learning curve for ultrasound learning. So it helps us in guiding many of the procedures because it is real time. So various conditions in the ICU can be diagnosed. I will not go into the details. Few latest which may help us in managing our critically ill patients would be weaning the patients from the ventilator, where weaning failure, associated diaphragmatic dysfunction which is occult can be well made out, and recruitment maneuvers using the ultrasound is also of help. Optic sheath diameter, assessing the ICP edema is also of benefit. So even in the cardiac arrest, a quick decision can be made and therapeutics can be achieved. Procedures, I can say, I think it has been a recommendation from various international bodies that central line HD catheters have to be done with the ultrasound only. And here I can recollect when almost 2010, 2011, one of my junior who is so good, she could do percutaneous tracheostomy with the use of ultrasound within 2 minutes. It is really remarkable. So few conditions which I would like to quote how it has helped the routine use of ultrasound. Any patient with hypovolemia. So more and more we are realizing that it is the fluid stewardship which is very, very vital. So judicious fluid resuscitation is vital and overzealous is adverse outcome. So we are aware and we have moved away from the static variables which are obsolete and they're imprecise. So with IVC and PLR, using ultrasound makes a big difference. There is significant correlation, sensitivity, and specificity also. So Society of Critical Care Medicine has made many recommendations as far as the general ultrasound or the advanced cardiac ultrasound usage is concerned. So according to SCCM, fluid responsiveness has to be assessed in all the septic patients. There can be associated occult acquired LV or RV dysfunction. However, it is very, very important to assess this patient and recognize either LV or RV dysfunction, because in them fluid is going to be more harmful and detrimental. So augmenting the cardiac output in these kind of patients is with vasopressors only. So we have the FAST protocol. Critical care echocardiography is also a must. Basic, I would suggest that all the resident definitely should learn at least the basic, where we assess the LV size and the function, RV size and the function, valvular dysfunction. However, advanced critical care echocardiography needs special skills, training, and credentials. So few situations where ultrasound will make a big difference is one of the case with pulmonary thromboembolism. So clinically, many a times our patients may not have specific signs pertaining to pulmonary thromboembolism. However, as I said, if the patient is very, very unstable, it is not feasible to move the patient to the CT. So it is the ultrasound which definitely helps us. A patient with a DVT and a RA-RV dilated, there is no other cause, and we are sure that it is pulmonary embolism. So European Society recommends justification for thrombolysis with documented RA-RV dilatation when we are suspecting PE with hemodynamic instability. Coming to pericardial effusion and tamponade also, there are characteristic features. And as I said, like I could save at least that particular patient with a diagnosis of cardiac tamponade immediately followed by pigtail. In the CPR also, it is very, very vital that ultrasound helps us. There are 5H and 5Ts. However, identification of underlying cause like hypovolemia, PTE, tamponade, regional wall motion abnormality, these are all very reversible causes. Definitely, if we intervene early, patient outcome is going to get better. Even the presence or absence of mechanical activity during the CPR has a prognostic value. It has been found that if there is a cardiac standstill, there is going to be 100% mortality. DVT, even despite chemoprophylaxis, 12% of the ICU patients develop DVT. So compression ultrasound by 5-point assessment by the intensivist has more than 95% accuracy. All these factors are suggesting that definitely the learning curve is good and we can make a difference in the patient's assessment and management. Coming to thoracic ultrasound, definitely lung ultrasound was probably not used by radiologists or non-intensivists earlier. I can definitely say and congratulate the experts who have pioneered and definitely made significant impact for the patient's condition. So we have LUCI, that is the lung ultrasound in the critically ill. So the philosophy of LUCI is no space for confusion, the machine, the probe, the signatures, the applications are considered with a holistic perspective. We have the blue protocol. We all should be thankful to Dr. Daniel Lichtenstein, who is the father of lung ultrasound. So in 1990 only, Dr. Daniel Lichtenstein started the international movement and basic competency for the ICU specialist was suggested. So lung ultrasonography is definitely superior to X-ray in dyspneic patient. So we have the standard blue protocol. So coming to pneumothorax, one of the clinical scenario which we commonly encounter resulting in cardiorespiratory failure. So there are few clinical signs which are very, very characteristic, like lung point, lung pulse, the barcoding being absent, or the stratosphere sign. So according to Society of Critical Care Medicine, ultrasound should be done to complement or in fact replace conventional chest radiography to diagnose a pneumothorax, depending on the clinical setting and the need for the rapid results. Because ultrasound usage and diagnosing pneumothorax has a sensitivity and a specificity more than 85% when compared to chest X-ray. Even with non-radiologists, ultrasound has a higher sensitivity and a specificity. Coming to alveolar interstitial syndrome, there are lung comets or the B lines, which even our interns are familiar with in our college where I practice. So there is a positive correlation with the extravascular lung water or the pulmonary capillary wedge pressure. So even in heart failure and even in patients with cardiogenic pulmonary edema, patients undergoing RRT, decrease in the B line suggests there is a significant recovery. And it is very, very important that these are one of the very early signs which develop whenever there is a cardiogenic, whenever there is a pulmonary edema, whether it is cardiogenic or non-cardiogenic. So again, coming back to the guidelines, because as intensivists, I think we are obsessed with the evidence. The Society of Critical Care Medicine recommends that there has to be a systematic approach incorporating bedside ultrasound, probably as a primary diagnostic modality for ICU patients with respiratory failure, because the sensitivity and specificity as far as the alveolar consolidation is concerned, it's more than 90%, and even other causes of etiologies resulting in respiratory failure, the accuracy is more than 90%. So the characteristic feature of consolidation are hepatization, Schrett's sign, and the air bronchograms. I remember reading hepatization in Robbins way back when I was doing my second year of MBBS. But now witnessing hepatization and diagnosing consolidation and making change in the patient's management definitely is pleasurable. Coming to pleural effusion, we can always make a diagnosis with hypoechoic or hyperechoic fluid in the ICU. Why it is important? Because if it is a hypoechoic, more or less it is a transudative effusion. If it is a hyperechoic, predominantly it's an exudative effusion. And with the lung ultrasound showing septations, if it is a small effusion, suspecting empyema, definitely pigtail has to be done using the ultrasound guidance only. So there is a strong recommendation from the Society of Critical Care Medicine for the same. So not only in diagnosing and making decisions for the treatment, the incidence of the complications also significantly gets reduced if at all we are using the ultrasound. So in one of the study, it has been found that the sensitivity and specificity of various respiratory failure causes has significant, more than 90% of sensitivity and specificity when compared to CT scanning. Like alveolar consolidation, we have a sensitivity with 90%, 98% of specificity with the ultrasound usage. Interstitial syndrome with various patterns also. Even in occult pneumothorax, if you can see, the specificity is 100%. So not only the earlier situations where lung ultrasound has played a vital role, even in the pandemic, there is a paper where lung ultrasound score has predicted outcomes in COVID-19 patients admitted to the ICU. So understanding and realizing the importance and the utility of ultrasound as far as the diagnosis is concerned and the outcomes are concerned, various international bodies have published various guidelines. Society of Critical Care Medicine, in fact, for all the juniors who are attending this talk, I would suggest please go through these part 1, part 2 guidelines from the SCCM. They are very, very good and very, very easy to understand also. So I'm definitely convinced and going to convince my opponent also that utility of ICU in the utility of ultrasound in the ICU is a must, and it has to be used because it is critical, indispensable. Live life full of humility, gratitude, intellectual curiosity, and never stop learning. Thank you.
Yeah. So Dr. Radha, thanks for the excellent pro discussion about ultrasound. But here, the one key thing, obviously your opponent, Dr. Sharmili is going to discuss her point. But here the key question would have been, is it a routine ultrasound a must in the ICU or not? in the sense you just a stroke patient after thrombolysis with an echo already done, just, before, patient coming to the ICU, whether you need to do in a stroke patient with urosepsis, patient has got a maxillofacial surgery, and that kind of patient who come to the ICU, whether you need, instead of, you do a blanket ultrasound is a must, or you need to do on focused ultrasound. You think about something, you suspect something, and you do something or not. That is the only key discussion here. So that's fine. So I will ask Dr.
Shall I answer, or at the end I'll answer?
That's it. No, that is the question. The debate is that basically. So I would like to ask Dr. Sharmili Sinha to just start her arguments. Dr. Sharmili.
Thank you, Dr. Ajit and Dr. Pradeep, for this excellent opportunity. And thanks, Dr. Radha, for actually deliberating and nicely elaborating the uses of ultrasound, otherwise the theoretical aspect, and also shared your experiences. But I would say I have an entirely different opinion, and it's just not for this evening or Procon debate session. Also, per se, for my experience of 17 years in full-time critical care, that I do not truly believe that ultrasound is a must, or routine ultrasound is a must in our ICUs. In the next 10 to 15 minutes, I'll just put forth my viewpoints, and then we can discuss. I believe my screen is visible. Yeah.
Yes.
Yes, sir, Malik.
Yeah. So you have nicely pointed out, like, why ultrasound, what is its role, and what all systems it helps you to look at and makes an accurate diagnosis. And few of these numerous situations that we are explaining in your presentations, it might lead you to a very focused intervention. But however, the topic of today's discussion is about routine ultrasound in intensive care unit. So that is something where I would agree to disagree. And the issues are enumerated here. So we'll cover these points in the next few minutes. So what is point of care ultrasound? All this length of time that you spent on actually explaining what are the uses of ultrasound, which you focused on making certain kind of diagnosis. So it might sound as a solution to a series of clinical conundrums when a patient is presenting to the emergency department in an acute critically ill, with an acute critical illness, maybe a pneumothorax or hemodynamic instability or a respiratory failure cases. So it has definitely the potential of differentiating among these few common causes of respiratory failure or hemodynamic instability. These are the two main segments that its role has been emphasized, especially when a patient presenting to the emergency department, or sometimes if they directly land up in the intensive care units. But all of this, as you narrated very nicely, and so many societies, mainly you were repeatedly quoting the Society of Critical Care Medicine and even European Society of Critical Care Medicine, and also there are recommendations from Spanish Intensive Care Society as well as separately. All this gathering together, if you look at these recommendations, these are all recommendations, and in these recommendations in themselves, there are connotations that they do not have robust evidence. So the evidence, because in this era of evidence-based medicine, we are of fans of evidences. We don't talk about it, and we talk about measurable, solid, measurable outcomes. And in intensive care, most of my colleagues would agree that we almost, first of all, when we talk about outcomes, what is it? It's mortality. But it does not apply to all kind of clinical scenarios or interventions or diagnostic tests. And because ultrasound happens to be a diagnostic test, we might also talk about the morbidity, and also if it helps you to spare other healthcare resources like other diagnostic tests like CT scans or other chest x-rays or other radiological tests or blood tests. And also if it has an impact on the length of stay, either in the ICU or in the hospital, and overall about the economical or financial implications. You can see this is a nice commentary actually, which was published in the Chest in 2019. So it's a recent one, where actually they have definitely criticized and they have expressed their genuine concerns about if the point of care ultrasound should be a routine practice in the evaluation of acutely breathless patients, where the authors have nicely quoted all the practical points and also the literature which have existed in this field in the last 2 decades. So if you look at this scientific evidence on POCUS, you see there have not been many randomized controlled trials, which has actually looked at its utility in terms of patient outcomes. Now, after that, actually, Pivetta et al., they published a multicenter trial where they looked at around 520 patients who were acutely breathless. And again, if you go through the entire study, what you find is there is a superior diagnostic accuracy of lung ultrasound compared to chest X-ray. You also cited a couple of good tables where you compared the diagnostic accuracy in terms of sensitivity and specificity compared to CT scan, chest X-rays. But it is, remember, it is a diagnostic accuracy. But did this superior diagnostic accuracy lead to a superior outcome like morbidity, mortality, or length of stay in the ICU or ventilator-free days? No. Literature is absolutely silent about that. And if you mentioned that Daniel has been the father of the ultrasound in the last 2 years, 20 years or 25 years. The length of time and I think billions of money have been spent on training and healthcare personnel on ultrasound. But if it is something disproportionate that strikes is the amount of evidence that has been generated in literature in supporting its role in giving better outcome to critically ill patients. So evidence is certainly lacking, and it is something we cannot, absolutely overlook here or cannot ignore this because it is largely absent from the evidence base, and it is not regarded yet as a standard of care in these populations. Yes, I agree. There are recommendations from different societies, but recommendations and guidelines are guidelines. And at the end of the day, at the bedside, the clinician's judgment and your infrastructural limitations definitely should dictate the practice. So there is an international consensus statement, which was published in 2012 on the use of focus. And it had a thorough overview of the core evidence base that has definitely underpinned the area of clinical practice over the past few years. Now you see this piece of publication. If you go through again this lengthy publication, see most of the studies that have been cited and discussed are small in nature. They're mostly expert opinions, and even to my surprise, I found some of the discharge summaries have been also discussed in this paper. So, and the participants of this study most have their counted on their length of years in the clinical care and their knowledge and their clinical experiences per se. So this means that the data which was presented in this are at most close to the best expected in terms of, again, diagnostic sensitivity and specificity. We looked at that Pivet's randomized controlled trial and this international consensus statement also, where there have been emphasized and there have accepted or endorsed the superior diagnostic sensitivity and specificity. Yet they are actually silent, or there has been silence maintained about their role in outcomes. So routine use of ultrasound in intensive care unit is definitely not the standard of care yet. Though the usage has definitely multiplied in progressions over the last few years, as I say. And again, in this lengthy consensus statements, you see there have been a good amount of bias regarding the patient selection or the choice of reference test against which the ultrasound was compared. So it remains really doubtful if this can be truly generalizable for a routine use in ICU, or it can be reproduced in different setups. And you'd agree that if you count the developing countries like India and the middle income countries, where ICUs have diverse infrastructures, this is definitely cannot be generalized or reproducible. Again, the lung ultrasound, which has been used to diagnose pneumothorax, have been largely confined to 3 etiologies. Mostly those are patients who have been already in the intensive care unit. They have been hooked on to ventilator, or if they had some kind of procedure performed, either a pleural tap or a central line. So in that particular clinic, or those who had history of trauma. So these are the clinical scenarios anyway. If you just take their good history and clinically examine these patients, it anyway gives you a high probability of having a pneumothorax if your lung parameters or ventilator parameters are going haywire. So in that context, if you are using ultrasound just before your X-ray machine arrives and you find lung line is absent and you diagnose that there is pneumothorax, I would not say it's a very big clinical superiority, because at the end of the day, the clinical skills of the doctors and the paramedic staff who are attending the patient is of far and foremost important, because this gadget is not universally available, and training and expertise of the staffs who are performing is also big questions. We'll come to that. So when you are comparing the efficacy or the diagnostic superiority of a lung ultrasound to diagnose pneumothorax in these particular etiologies versus a probability of diagnosis in diagnosing a pneumothorax in a patient who are unselected, who are otherwise directly present into the emergency department with acutely breathless state. There will be a huge difference. So ease of detection and diagnostic reliability by ultrasound in this unselected cohort of patients certainly remain uncertain. And this has not been addressed in any of the literatures that have been published so far. I think you cited this blue protocol about which was published or led by Daniel himself. But even again, if you look at this is a free article, I would appeal to the audience, my colleagues here to go through this article. It has actually many patients. So he has excluded many patients who had uncertain diagnosis. Again, only those three categories of patients or patients who by means of their clinical history or the course of the disease per se, those who had high probability of pneumothorax or lung pathology, they were only included and assessed in this study. So obviously, because this uncertain or the difficult category of patients were already excluded from assessment, outlook definitely looked better. Many of these reference tests have been again case series or viewpoints, which have been far from accuracy or consistency. This is another single center but randomized controlled trial. It was a large one, which looked at unselected emergency patient. And they also found the greatest gain was in diagnosing heart failure and pleural effusions when ultrasound was used in these patients. And there were less significant positive changes in other common diagnosis cases. So again, there was no impact on the long-term outcomes as in terms of length of hospital or ICU stay or mortality. This is about international evidence-based recommendation about focused cardiac ultrasound. I think you also cited this. This is something where they have only cited or they have put recommendations regarding cardiac ultrasound. Anyway, 2D echo, which is part and parcel of advanced cardiology, incorporates this, and these have been only repetitions of those. So I would say using ultrasound routinely in an intensive care unit is very, very different from using cardiac ultrasound, which is the 2D echo for assessment of patients who are suspected to have cardiac dysfunctions of various causes, is entirely different. So I do not see any place of having routine ultrasound every day in an ICU. If you're, this is an interesting commentary that I found and I thought of sharing with you, that if you ultrasonography in the intensive care unit, and it makes you look at the world through colored glasses. Obviously, the world looks quite colorful, but it's not necessarily helpful. Now, it's a good table which tells you what all areas where ultrasound can be applied in intensive care unit. And if you think this is going to be a routine application of ultrasound in intensive care unit, I would certainly discourage that. And I think most of you will disagree with me, because this machine, because after it's a tool and it can be applied from head to toe. Everything you are starting from the optic nerve sheath diameter to position of the hydrocephalus. TCT is a different ballgame altogether. And coming to neck, again, the airway, all these arteries, veins, and thoraxes, it has definitely a role, but again, it's confined to certain etiologies. Abdomen, it is hosting numerous organs, and apart from in the setting of trauma, looking at other organs like gallbladder, kidneys, or your liver, or other etiologies, if you're trying to assess or ascertain by using a routine ultrasound in the intensive care unit, I would say that will be a waste of time. And because most of these diagnoses, if they need to, they are help you to, or asking for exploration or treating you to some intervention, it needs to be endorsed by a professional radiologist. Again, looking at the extremities for DVTs on a daily basis, I would not say it's a great idea, except for a certain cohort of patients or a subset of patients like neurocritical care patients who might be having an ICH or a traumatic contusion. Those patients, if there is a dilemma or hesitation in starting a pharmacoprophylaxis with heparin, those are the cases you might look at those limbs with routine ultrasound at times to exclude deep vein thrombosis. But otherwise, conducting ultrasound on a daily basis for a critically ill patients, depending on the predominant etiology, to look for all these pathologies is not a bright idea. So it sounds too ambitious to have a routine ultrasound in the ICUs. These are some of the etiologies probably where it might give you some idea, but conducting ultrasound to look for all these etiologies in a routine ICU is not going to be a practical idea. It is said that an adequately trained intensivist could perform this initial full ultrasound assessment in no more than 15 minutes. So it's $1 million question. Who is an adequately trained intensivist in ultrasound who can perform this this big list of ultrasound of all systems possible on the body and can complete it in 15 minutes, and then you amalgamate and process that information to generate a treatment plan and for the best of patient outcomes. So I think it sounds just too ambitious and impractical. Now let's look at the training requirements. This have been proposed by some of the societies again. And there's training requirements for ultrasound again have been divided into basic and advanced trainings. So these are the basic ones. Again, you need to the principles and this ultrasound by syndromes like all the organ systems regarding cardiovascular systems, the pulmonary system, and other abdominal organs that we're discussing, and also if you're considering the neurological system. And if you're going for interventions, you need to have a separate set of training for that. So the limitations are aplenty, and we need a specialist opinion when finding some impact on decision making or to avoid diagnostic or treatment error. And certainly these also have medical legal implications, which should never be the only information taken into account in making decisions. Integration of data, which is obtained from starting from the clinical history and then clinical assessment and from the basic investigations, should definitely be integrated before we start acting on these findings. So monitoring of these patients and complementary test information should be put into use. Now, as we discussed, the training requirement in itself is a big issue, especially in the Indian countries like in India and the subcontinent. There have been certain recommendations. This one by is the Spanish Society of Intensive Care Unit. And after they delineated this training requirement for the critical care doctors of various statuses, there was lack of consensus among them, and it has not been put into guidelines or put into practice in these countries in themselves. So, and this is a practical thought I thought I'll share with you. So most of this critical care workshop, most of you have been probably faculty of it or may have been delegates of it. In a workshop, when it is conducted, it is conducted on a very lean, thin, slim patient who is a very ideal patient, and you just put the probe on these patients, and every possible organ inside is visible, and you feel I can see the heart pumping, the LV function, the cardiac pericardial fluid, right, and even the lungs. Even all 4 quadrants of the abdomen, everything is easily visible. And when you actually come to a patient's bedside, we have such a morbidly obese patients who had the ward. We have gone and intubated these patients, and this is a real patient in our hospital. And you have tubed these patients, you have resuscitated these patients. Now, who is going to do ultrasound on this patient at 2 a.m. in the morning? Now, it is not possible to train each and every critical care doctor, maybe in the various stages of their training process, to be an expert on this, apart from very subtle clinical diagnosis like pulmonary embolism, but also there are issues in conducting the ultrasound on these kind of patients for obvious reasons. So now let's take a clinical scenario. Suppose a 62-year-old male comes to emergency department with shortness of breath, and there is swelling of both legs to some extent. Is a known case of diabetes, hypertension, and coronary artery disease on double antiplatelets. This is a real-time cases, and very often we see these kind of cases in our hospitals. The saturation is low, 84% on room air. No history of fever. Blood pressure is maintained, 114/78, slightly tachycardic, and respiratory rate is slightly high. Now, what will you do in the emergency first? So anyone would definitely, as we go by our standard teaching, and would now like to also continue in the past, present, and future also, one must take adequate history and then go for clinical examinations. Now, I would like to know from my colleague that would you like to go for clinical examination first, or would you like to go for the ultrasound first? So this is $1 million question, because as this gadgets are evolving and there is a lot of noise about use of ultrasound in the intensive care unit or even in emergency settings. So there is a craze among the young generation doctors that they should all be having an ultrasound in wherever they are working, and they should be trained in this, but it is far from reality that you cannot train all the medical workforce who are working in the acute care setups, be in the emergency or intensive care units, or who are attending this calls in the wards in this particular specialty. So I would say gadgets are only supplementary to clinical assessment, not a replacement for our clinical skills or assessment. So other very common ones that we see in our ICU is about, you mentioned about, years ago, probably most of the societies have put recommendation for using the ultrasound while putting internal lines. Now, for using ultrasound for for internal jugular lines or for femoral lines or even for PICC lines is okay. But what about subclavian lines? Very commonly also we do subclavian lines for patients, and especially for patients who are actually risky or patients where I would actually like to use an ultrasound for a patient who is hooked onto a ventilator with high PEEP. And if you're planning a subclavian line, can you use ultrasound in these patients? The answer is no. So then why it has been mandatory for, kind of places, kind of lines where it is otherwise also easier to do. And most of us would agree that during our training times, we did not have ultrasound, and we were taught by this traditional classic methods of ascertaining the landmarks, the triangle, and the safety points that we need to know. So this ultrasound is not, readily available at all kind of healthcare centers, be it primary, secondary, or even in the wards also where the lines are being put these days, or even oncology centers, or even for the daycare basis, the lines are being put. It is not feasible to have ultrasound machine at every place. So the logistics are a big issue. Now, regarding price or the cost of an ultrasound machine, depending on the brand that you're going for in the market, it ranges between 5 to 8 lakhs rupees per machine. Compared to that, a stethoscope, if you're going for a good quality, something varies from 1,000 rupees to 3,000 rupees. Now, having one ultrasound per ICU, which will be utilized, say, 10 to 15 patients, depending on your brain strength, I would prefer to have stethoscope for each patient for the bedside of 10 or 15 patients. And this can be replaced, if they're getting damaged or needs to be replaced. But it is not so. So it's also a expensive affair. You said that expensive safety is priceless, but I would say safety, even if it is priceless, we agree with that, but it has definitely comes with a cost, and cost has to be generalized. It should be practical and bearable, because if you put in guidelines that ultrasound should be used for each and every of the procedures that we look at this ambitious list, it is not feasible and cannot be extrapolated. And actually, it will put us in a lot of trouble later on, when times are not far, when patients' relatives and even administrators can start telling us that why didn't you use ultrasound for each and every procedure, because there are recommendations for Society of Critical Care Medicine United States or ESICM Europe. So that is something is not generalizable, not reproducible in every setups. So training is a big issue. Maintenance of the machine is also a challenging. And if you are using only one machine, suppose you have intensive care units in different floors, and that is the situation also in many hospitals. There are units are located at different floors. You cannot be transporting one machine between 3 ICUs. So you got to have, if you have a policy, one ultrasound for each ICU, which is again a difficult situations. And what about infection control practices? When you're using this ultrasound probe, every time it has to be cleaned. And if you're performing the lines, that particular sheath, compatible sheath has to be used. And I do not see, having this accessories and everything, it also compromises. In my 17 years of clinical practice, I've seen it compromises infection control practices, and also the cost adds to the cost due to the accessories. COVID-19 cases, in the last 1.5 years, we have seen when we had the peak of the first wave and the peak of second wave, we had seen that ultrasounds were not very commonly, could not be actually used for these cases, because many places did not have multiple ultrasounds for these COVID units and non-COVID units. So replicability was not also a practical points. So summarizing the take-home points, I would say ultrasound actually it's a techno-savvy mind that we have developed over a period of time, which is keen for gadgets and is in a hurry to acquire a lot of information in a hurry, but not sure how to handle and process that information, and so as to carve out a best treatment plan for these patients, aiming best of outcomes. I would rather prefer to train and strengthen my team and build their clinical skills than investing all efforts in training and certifying for them in ultrasound when the guidelines are themselves not clear and it varies considerably from place to place. Our expertise in ultrasound, ultrasound is definitely as a useful tool, but it's a useful adjunct. It is nothing that should be routinely performed in ICUs. It will certainly develop over a period of time, but it is not a must as a routine procedure in ICUs as of now. The repercussions also having such mandates are far too many because it is not a reality, it is far from reality. And also, as I mentioned about it has got medical legal implications as well. So focus on the point of ultrasound count is a useful adjunct in management of acutely ill, critically ill patients. But routine ultrasound is ICU is certainly not a must and neither is desirable. It has some benefit in diagnostic accuracy, especially in pulmonary edema patients who have got pulmonary effusion and pneumothorax of certain etiologies and of certain cardiac etiologies like acute cardiac pulmonary thromboembolism or cardiac dysfunctions. At best, in suitable patients again. Training and standardization still remain an issue, and we are far from reaching those standards and its impact on clinical outcome. There remains still a severe paucity of evidence in literature so far. So clinical common sense should not be replaced by these modern gadgets, and basics of clinical science must prevail. And I would say that, and would appeal to my colleagues who are sitting here together this evening, that ultrasound should not replace stethoscope in ICU still. So routine ultrasound together should not be a common practice in ICU. I will end my talk here.
So thank you, Dr. Sharmili, for the excellent discussion. Dr. Radha, you want to add anything? You want to?
Yeah,
You want to
yeah, few
anything?
points. Yeah, definitely. First and the foremost, even I emphasize that it complements the clinical examination. I didn't say that it replaces the clinical examination. I'm proud to be a clinician next to the patient, definitely. So I think we all are aware that what the mind doesn't think, the eyes cannot see. So in that respect, definitely ultrasound complements my thinking process and logistics next to the patient who is critically ill. Whatever you said, no, I think the one article both of us quoted, that is from the anesthesiology. Basically, that is, one second. I think that was 2012, ultrasonography in the intensive care unit, looking at the world through colored glasses. In that particular issue only, 125 consecutive critically ill patients underwent general routine ultrasound. And this included 12 hours post their admission to the ICU. So in fact, they could modify their initial diagnosis with the utility of routine ultrasound in 26% of the patients, and they could confirm the initial diagnosis in as high as 60% of the patients. However, it was not effective in just less than 15% of the patients. So definitely ultrasound, routine ultrasound. In fact, I do practice that. It's not that like I don't practice routine ultrasound for all my patients after my clinical assessment and making a plan. Before that, definitely I would do a ultrasound. Legal aspect, what Justin asked in India, I'm not very sure. The next thing is, certification. Certification, in fact, even the basic ultrasonography, I don't think so, whatever the literature I have gone through requires any competency or certification, but advanced cardiology, European Society has definite credentials. I think it has to be certified. Credentials are also there. It is well in path. So there is no doubt in that. Then the cost aspect. I think, for example, like if we are not doing repeatedly, many a times what happens, like PAN-CT is advised for patients with trauma. I don't think so it is recommended, even with the ATLS guidelines also, which we follow across. And guidelines, though they are opinion, many a times that is probably the available literature with which we practice our critical care. So in that respect, we cannot just negate that it is just a guideline which is recommending. Then coming to the infection control practices with the usage of ultrasound machine for procedures. In fact, like I have worked in closed ICU, I have worked in open ICUs also. If we think, whoever the leader is, thinks that it has to be done, it is recommended, it has to be done. So we use what is called as a transparent sleeve for the ultrasound probe, and that will be disposed, and definitely it will be cleaned with the chlorhexidine. So this much of infection, what is the guidelines? I'm not very sure. Cleaning the probe, but however, at least we do this much of infection control practices. So I still emphasize that yes, routine ultrasound should be part and parcel for an intensivist by the side of the patient in the ICU, and it should complement the clinical examination. Clinical examination will never go away. So clinical examination is always there. Added on to that is the routine ultrasound.
Radha, I'm glad to know that you are working probably one of the excellent tertiary care ICUs in the country. You mentioned about that article about seeing the world through the colored glasses. Yes, I was from the beginning, I have been emphasizing on that. It has got definitely diagnostic superiority. That's it. But when this can be extrapolated to best of clinical outcomes or to formulate a best or better treatment plan, that is where we are lacking in superiority. There's a striking difference. If you just, I would like to definitely point out or draw your attention to it. See, compared to 25 years since Daniel started this, ever since now, till now, there has been no robust data which can be, which points towards best or better outcomes when this routine ultrasound has been utilized for care of critically ill patients in ICU. Why so? So why this gap in the usage when there is a geometric progression, the usage has increased, but why there is no literature about it? So many drugs have come and taken a full circle or gone into oblivion. But this ultrasound has been, usage has been evolving like anything. But still, after 21 years since 1990, there has been no robust data again which has favors that its usage improves the clinical outcome of critically ill patients. That is something is striking. And in this context, in a previous debate that Dr. Anirban and Dr. Were engaged, that we heard them saying that. So I would say that we cannot ignore or overlook this paucity of data, I would say, because, we know this 1.5 years, so many drugs have come forth and gone criticized. And even some publications in some of the reputed journals also, how they have taken full turns, that has also been very appealing to me. So I would say that as still that debate is probably not being much quoted about remdesivir versus ivermectin. We all know the stories and the controversies which are underneath, probably not being discussed so far. I would do not want to bring up this controversy here, but this aspect of commercial interest of using the ultrasound versus routinely in all ICUs, that is something I'm against. It is definitely a useful adjunctive tool in certain category of patients, and that will be a more complete way of stating the summary or the conclusion today. But routinely using it in ICU and putting forth recommendations for its routine use in every ICU, I would stay away from agreeing to that at this moment of time. And you mentioned about the Society of Critical Care recommendations. You see, that is a great 2B evidence. And also, there is a point, it may be. They have, so this kind of recommendations actually many times puzzles me. There is in the statement itself, they have inserted an maybe for the use of patients or clinical care of patients in intensive care unit, and they have given them the grade of B. So this do not match. So always blindly following this recommendations of different societies, it sometimes actually we have to be a bit wise and thoughtful, and we have to also think that if this can be extrapolated to our own setups, where things are so diverse, so heterogeneous. If you look at the INDICAP study, probably less than 10% of Indian ICUs have ultrasound. That was obviously a few years ago. It might have increased a little bit, but it's just still from all our ICUs of secondary or tertiary kinds who might have even the machine itself, let alone the training requirements, the expertise, and they have protocols to interpret and use it for patients' care. So keeping all this, the bigger picture in mind, I would say that routine use of ICU, routine use of ultrasound in ICU is still, we are far from that. And probably it is nothing that it's a must. We still must, evidence is emerging, and we might still get better trials in future, which might guide us better to debate on this.
Just one point, Dr. Ajit. No, the thing is, even the grade also, like, there are general ultrasound, advanced ultrasound, general cardiac, basic cardiac, and advanced, correct? So all the recommendations, there is a gradation. There are few recommendations which are grade 1A, 1B, like that. So see, because their guidelines are always opinions, correct? No? So we practice that bedside, but probably that is the starting point for us, because we cannot say that that was from a different society. We will not practice like that. So I would say that yes, definitely it is the final decision is by me only next to my patient. But however, these definitely give us some information where we are supposed to, the standard of care has to be practiced for most of the patients. That's what I believe in.
Yeah.
And
So
yes,
ultrasound in intensive care, if we are not refuting it, is definitely, I repeat, and have
no,
been
one second,
repeating
I
it
haven't
throughout. It is a
completed.
useful
I haven't
adjunct.
completed.
Yeah.
No, even as far as the routine usage also, the acceptance because of various confounding factors across the globe is also not very uniform. So in that respect also, if there is a diversity in utility of ultrasound itself, then we will not have better evidence also, which is evolving. There is a discrepancy even in the usage of the ultrasound. First of all, the people mindset has to change. That's what I would strongly emphasize.
So thank you, Dr. Radha, Dr. Sharmili Sinha, for the excellent discussions, because the discussions, whichever way they are, whichever direction they are, basically we tend to learn a lot by the discussions. So see my personal perspective, because I am a sort of medium guy in ultrasound, supporting or refuting ultrasound. But I strongly personally believe that probably the best way to do ultrasound will be a focused ultrasound, rather than some kind of a routine blanket ultrasound. And my major concern is the infections actually. So there has been increase because recently I was lucky enough to some kind of a letter to editor was we have along with Dr. Justin, we have put it in the Indian Journal of Critical Care Medicine about the VAP diagnosis with ultrasound. The major issue when we went through the literature and even our own observation, we can say obviously the N and all is always debatable, is that there is an increasing reports of increasing infections with ultrasound probe all over the world. And what our observation has been, like whenever the ultrasound interventions are more mean, these patients tend to have more and more infections. So that is one concern, because if you do the routine ultrasound, obviously time consuming, cost and all is a thing. Then the issue with infection. Maybe tomorrow, because somebody is going to bring out with a no touch ultrasound. It's my imagination, like just like CT scan, you keep the ultrasound probe from a distance, and then you are able to see the thing and you are able to assess the thing. Maybe that could be the future without touching. This is my imagination. Second thing is that the stethoscope can never be thrown away. I am a bit emotional in that. What I mean to tell you is that even see the infection issue, what I was telling previously, will be compounded in a crisis like COVID, where there's a severe shortage of manpower is there, and the infection is very likely to be compromised, and that is what concerned. And even when we talk about the ultrasound, the stethoscope thing, what I want to share is that at least in my experience, obviously the N is only 3, but in at least 2 or 3 patients during the COVID time, when most of us are wearing very tight the PPs and all, we tend to not to use obviously most of us did not ever use this like stethoscope oscillation we have never been doing. At least 2 or 3 patients who are ready to be extubated. They are ready to be extubated with the near normal X-ray. They started suddenly with some kind of a gasping and all. We have been discussing the diagnosis of a normal X-ray with breathing difficulty, like neuromuscular disorder and all. And when you oscillate the patient, you can see that they had severe bronchospasm. And unfortunately, because of COVID crisis, there is a lot of difficulty was there, even history taking and all that sort of thing. And we mixed it. So what I mean to tell you is that I'm a bit emotional in that, because I, being a pulmonology background in my mind, bronchospasm can never be detected with ultrasound, at least based on the current thing. So unless you oscillate the patient and you do whatever with ultrasound all along, but if you don't oscillate for a bronchospasm, it can be missed actually. And the basic conventional teaching is that one of the most important aspect of weaning a patient is you need to rule out bronchospasm. So whatever you do, if you don't oscillate the patient, sometimes the crucial bronchospasm can be missed, and it can be detrimental to the patient's life. Third thing is, as you said, people who are using the ultrasound also should know the limitation of ultrasound. As you said, ultrasound, I want to reiterate 10 times that it cannot detect bronchospasm. And even the Lichtenstein, the Daniel Lichtenstein is the proponent, the father of the ICU ultrasound. He has written an article in Chest. It is called Current Misconceptions in Ultrasound. So basically, it's in Chest in 2019. Anybody can Google and see that current misconceptions in ultrasound. He has told that even the consolidations and all, it can be seen in other conditions, even in pulmonary edema. Studies have shown that his own observation and studies have shown that pulmonary edemas, even in pulmonary embolism, even atelectasis, even in some kind of tumors and all that sort of conditions, the consolidation can be seen. So basically, sometimes, unless you unless you use our own interpretation just based on the ultrasound picture, you make some assumptions and all can be sometimes very determinant as well. And then even the fluid responsiveness on the base of the IVC collapsibility, because the more than 50% IVC collapsibility sort of thing has got a sensitivity of only about 67%. So that means 1/3 of the people, even the patient does not have the collapsibility, if you don't give the fluid just based on ultrasound, and sometimes you'll be losing the patient. See, these kind of things are there. That is what I want to add about that. And I personally prefer, focused ultrasound rather than a routine blanket ultrasound. And my major concern is the transmission of infections. So I just requested Justin or Pradeep and any audience to add something to this.
Again, I will reiterate that it complements clinical examination. I am proud to be a clinician next to the patient. Definitely it complements. I'm not telling that we should, the moment the patient is wheeled in with the respiratory failure, I'll use the ultrasound probe and start making diagnosis. Definitely not. Definitely I will assess the patient, focused history, make some impression, then do my ultrasound and probably confirm or rule in or rule out my diagnosis and then take it from there. Definitely clinical examination first, followed by ultrasound.
Yeah, thanks, Ajit, Radha, and
Yeah,
Sharmini
yeah.
for excellent Procon. I think
Yeah.
both of them agree, Ajit, that we cannot undo the clinical examination, and any aid that we use is only an adjunct to the good thorough clinical examination. Only I just need to make one remark that whatever we embrace in an overwhelming way in our scientific medicine or modern medicine, we have always been humbled by the same tool that would get debunked eventually, Ajit. So I believe we should have a tempered enthusiasm, so not overwhelming enthusiasm to embrace any tool. And the clinical
in one line, it may be called as a compassionate use of ultrasound. I am just returning back from where I heard someone talking about compassionate use of adjuvant therapy in sepsis, and I related with ultrasound and find that it can be a compassionate use of ultrasound in ICU.
Yeah. So yeah, tempered enthusiasm may be a better word. Compassionate has a different connotation, Anirban. So I think that would be my submission, Ajit. But excellent discussions. But I think both of the debaters do agree, isn't it, Sharmili and Radha, that nothing can substitute for a good, thorough clinical examination, and all other tools that we use in intensive care, be it biochemical or investigative modalities or imaging, will act as a good adjunct. But routine, the word routine ultrasound, which was the contentious debate that we had, I think that we can all agree that routine has no place. Am I reasonable in saying that?
Yes, Dr. Pradeep, I agree that routine and must. These two words I disagree. It is definitely a useful tool, an adjunctive tool, but routine and must. These are something that I would agree to disagree.
I think rather disagree. So I'll leave it to other wise men to make comments.
There is an angle. If you see someone is doing routine biomarkers, someone is sending routine lactate, someone is sending routine Procon. So in that case, if you see routine ultrasound takes a much lower pedestal. So it should not be waved off like a damn pimple.
Yeah, I think Radha doesn't agree. Justin, you have any comments, and then we'll take final comments from Radha.
I can see it was an uphill battle from the time it was announced, because not just that the debater, but also many of the hosts, including Ajit, were not in agreement with as a bias against routine use of ultrasound, including me. So working with Radha before, we all, how she said, we agree to disagree, but we undertook what we call as a standard of care. I mean, we used it as an investigation, judicious use of an investigation. The ultrasound is an investigation. It is not a clinical examination tool. So that's where the differentiation is. The people, when they use ultrasound as a replacement for a clinical examination tool, and that's when water becomes murky. And then the word routine becomes, because you have to routinely examine a patient. So when you use an investigation to replace clinical examination, then the routine becomes norm for them. And that's certainly in some specialized centers, like Radha has worked, that they probably have done that very well. But at the end of the day, most of these highly skilled centers have bigger number of patients, and then use of ultrasound has its own, like Ajit said, infection implications, and when you're used on many patients, it becomes more sensitive than specific as in any investigation. So these implications are to be kept in mind. So the discussion is all about whether ultrasound is it an investigation or a clinical examination tool. So that's where the whole premise of this presentation is, what I thought. And as it stands, we should still treat it as an investigation to get maximum out of it, is what I think.
Yeah, Dr. Justin, actually, you articulated very well. And I congratulate Dr. Radha that she works one of the excellent tertiary level hospitals or intensive care units in the country. But me, having worked abroad in even in metro cities of India, now I'm in a tier B city in Bhubaneswar, is still one of the tertiary care units. But also I do go to secondary level ICUs or smaller ICUs, where I not only see patients and also train the staffs there. So having seen all these kind of infrastructures and the variety of the medical workforce or the paramedical workforce, I would still reiterate that routine ultrasound should not be recommended for management or treatment of intensive care critically ill patients in ICUs. It should be used as an adjunct therapies and in a focused manner, as Dr. Rajit rightly pointed out, keeping the clinical context in mind. And of course, in certain emergency situations where you have the available manpower is there and the machine is also there, you can obviously put it into use to delineate that information. And I agree, because that's also presented from my experience, that it has some implications in infection control practices as well, again due to logistic issues. So thank you very much, and I think it's over to you.
Thank you, Dr. Radha, Dr. Sharmili, for the excellent discussion. All of us have learned some new ideas from this. Thank you very much. Pradeep, you want to say a few words, man? Thanks. Thanks.
No, thank you. And I think Raja wishes to just address the audience for partnering with us in helping with these scientific deliberations. So, Raja from Microlabs.
Thank you very much, sir. I think it's been a much awaited Procon debate series that I think this is something a signature dish, the way we call it in ISCCM, and that there has been always an excellent way of receiving this Procon debate, and this is what we had been getting this as a feedback when we had been coordinating to engage our doctors into this program. So I think there's been a very interesting scientific discussions across. We are very thankful to Dr. Ajit and Dr. Pradeep ji for having moderating this session, and as well as all the senior faculties who have delivered your talks for the evening. So thank you very much for all the participants who have been patient enough. We did register almost close to about 150 people today who have been lively watching this program. Although we had 300 registrations, so we'll wait and watch how many of them see the program later. So once again, I thank each and every one of you for sparing your valuable time, and thank you very much once again, and we look forward to meet you in the next Procon debate series. Over to you, sir.
Thank you. Thank you all.
Thank you.
Thank you,
Immense
Radha.
thanks to Dr. Pradeep and Dr. Ajit and the team.
Thank you. We'll meet again.
Thank you, madam.
Take care. Yeah.
Good night.
Thank you.
Yeah, thank you. Thank you.
Thank you.
Thank you, Anirban, for your words of wisdom.